Your patient can't breathe. It came on in seconds, and now she is fighting for every breath. You listen, on the right side, nothing, no breath sounds at all. The trachea is pulled toward the left. Her neck veins are bulging, and the blood pressure is falling fast. Air is trapped in her chest under rising pressure, crushing the lung and squeezing the great vessels. There is one thing to do, right now, and it is not an X-ray. What is it? Here is your question. A client has sudden severe shortness of breath, absent breath sounds on the right, a trachea deviated to the left, distended neck veins, and a blood pressure of 80/50. Which action is the priority? A. Perform immediate needle decompression. B. Obtain a stat chest X-ray to confirm. C. Apply high-flow oxygen and reassess. D. Insert a chest tube. Pause and commit. 3, 2, 1. The answer is A. Immediate needle decompression. This is a tension pneumothorax, and it is a clinical diagnosis, which means you recognize it at the bedside and you act, without waiting for a picture. A hollow needle into the chest lets the trapped air escape and drops the pressure in seconds. It converts a killer into something stable. The X-ray, the chest tube, all of it comes after you have let that air out. Here is what is happening. There is a breach in the lung or the chest wall, and it acts like a one-way valve. Every breath, more air is pulled into the space around the lung, and none of it can get out. The lung on that side collapses, and the pressure keeps climbing. Soon it shoves the whole center of the chest, the trachea, the heart, the great veins, toward the other side. And when those veins are kinked, blood cannot return to the heart. The output falls, and this is obstructive shock. So you have to tell two things apart. A simple pneumothorax is stable. Breath sounds are down on one side, but the vital signs hold. There is no shift. And you have time for a chest X-ray, oxygen, and a chest tube if it is large. A tension pneumothorax is a different animal. The pressure is building, the trachea has shifted, the neck veins are up, and the pressure is dropping. That patient has no time. You decompress, on the spot. So here is the order. First, decompress, right now, a needle into the chest to release the trapped air. Second, place a chest tube, the definitive fix, to keep the lung re-expanded. Third, support and confirm. Oxygen, monitoring, and yes, the chest X-ray, but now, after the emergency is broken, along with a search for what caused it. Needle first, always. Here is the rule to carry out of this: a tension pneumothorax, respiratory distress with absent breath sounds, a shifted trachea, distended neck veins, and falling pressure, gets an immediate needle decompression. It is a clinical diagnosis, so you do not wait for the chest X-ray. Then the chest tube makes it definitive. So how do you know it is a tension and not just a pneumothorax? Look for the hard signs, together: sudden, severe breathlessness, absent breath sounds on one side, a trachea deviated away from that side, distended neck veins, and a falling blood pressure, shock. On percussion, that side sounds hollow, hyperresonant, and it does not rise with breathing. That full picture, distress and absent sounds and shift and shock, is your green light to decompress, not to image. 2 moves, and the order is everything. The needle relieves the pressure, fast, in seconds, buying you the minutes you need. But the needle does not fix the lung, it just lets the air out and converts a tension back into a simple pneumothorax. The chest tube is what re-expands the lung and keeps it open, the definitive repair. But it takes time to place. So the needle goes in first, to save the life, and the tube follows, to finish the job. Now 2 instincts that turn deadly. First, waiting for the X-ray. It feels responsible to confirm, but a tension pneumothorax is diagnosed by looking and listening, and every minute spent confirming is a minute the pressure keeps climbing. The patient can arrest while you wait for the film. Second, going in on the wrong side, or missing the spot. Decompress the side with the absent breath sounds, the side the trachea is shifting away from, and hit your landmark, so the needle clears the air, and not a vessel. 2. To lock in, to spot attention, the Ds, dyspnea, severe and sudden diminished, or absent, breath sounds, a deviated trachea, pushed away, and distended neck veins. Add a falling pressure and you have it. And for the needle itself, the second intercostal space at the mid-clavicular line, or, by newer guidance, the fifth space at the anterior axillary line. Either way, you pass the needle over the top of the rib to spare the vessels beneath it, then a chest tube. Now the wrong answers. B. Get a chest X-ray to confirm. It feels safe and thorough, but a tension pneumothorax is a clinical diagnosis, and the delay can kill. You decompress first, and image after. That is the trap. C. Oxygen and reassess. Oxygen helps, but it does nothing about the trapped air or the collapsing circulation. The tension keeps building underneath it. And D. Insert a chest tube. That is the definitive treatment, and it is coming, but it takes time to set up, and the needle is the move that saves the life in the meantime. Tie it together. Your cues: sudden, severe shortness of breath, absent breath sounds on one side, a trachea shifted away, distended neck veins, and a falling blood pressure. Your action: immediate needle decompression, then a chest tube for the definitive repair, with oxygen, monitoring, an X-ray afterward, and a hunt for the cause. And the outcomes you are steering toward: the tension relieved, blood returning to the heart again, the lung re-expanded by the tube, and the shock reversed. Now test yourself. Same story. Sudden shortness of breath, and breath sounds are down on the right. But this time, the vital signs are steady. The blood pressure is fine. The trachea is midline. And the neck veins are flat. Do you grab the needle? No. Without the shift and the shock, this is a simple pneumothorax, not a tension. You have time. Get the chest X-ray, give oxygen, and place a chest tube if it is large. What changed was not the collapsed lung. It was the absence of tension. One more. Hypotension, distended neck veins, a patient in shock, it looks like a tension. But when you listen, the breath sounds are equal on both sides, the trachea is midline, and the heart sounds are muffled and distant. Do you needle the chest? No. Equal breath sounds and muffled heart tones point somewhere else. Blood in the sac around the heart, a cardiac tamponade. This one needs a pericardiocentesis, a needle into the pericardium, not the chest. Same shock, different trap. Listen before you stick. One last patient. Blunt chest trauma, decreased breath sounds on the left, and hypotension. It could be a tension. But you percuss, and instead of a hollow, hyper-resonant note, it is dull. Do you decompress? No. Dullness means fluid, not air. This is a hemothorax, blood filling the chest. The fix is a chest tube to drain it, plus fluids and blood to resuscitate, not a decompression needle. Air is hyper-resonant, blood is dull. The percussion note tells you which. Next episode. Again, a patient suddenly gasping for air. But this time, you listen. And the lungs are clear, both sides rising evenly. The chest film looks normal. And yet, the oxygen will not come up, and the heart is racing. A clot has broken free and lodged in the lung. What is killing her, and what do you do? That is episode 14.